Bill, thank you for the kind introduction. I really appreciate Chris Keysweater and the Health Cell for having me here this evening to talk to you. And I also appreciate the fact that the people I work with at VPS, Vascular Perfusion Solutions, are hosting me and my family for dinner. Okay, so my story begins in San Antonio at Wilford Hall Medical Center in January 1985. I was a resident in pediatrics. I was rotating through the neonatal intensive care unit. And when I was there, I was part of a team that did something historic. We were the first in San Antonio, the first in Texas, the first west of the Mississippi all the way to California to use a new, innovative, very risky rescue therapy to save the life of a dying infant who did not respond to maximum conventional therapy. That therapy is called ECMO, Extracorporeal Membrane Oxygenation. Now, the diagram you see is simple. The bottom line on this is that blood is drained from a large blood vessel, a vein, goes to a pump, and it then goes to the membrane oxygenator, the artificial lung. And in this configuration, it returns to one of the major arteries of the body. Think of this as cardiopulmonary bypass used every day across the world for heart surgery. Think of it as that on steroids, because it can be used not for hours, but for days or weeks, and in my case, even longer. The other thing about this configuration is that it can fully support a failing heart and fully support failing lungs. Now, the photo you see is from Lurie Children's Hospital in Chicago, Illinois. That is what it looked like when we performed ECMO 20 years ago. Now, I'm going to ask anybody that can find the child in there to stand up. That's the first thing. But I really want to point out the big, clunky, difficult to use technology that we were using. But I also want to point out that that tan box smack dab in the center of the photograph that has some dials on it is a high-frequency ventilator that was developed in San Antonio, Texas in the 1980s as a collaboration between neonatologists at Wilford Hall Medical Center and Southwest Foundation for Biomedical Research, Texas Biomed. That device, in both a pediatric version and adult version, is used across the world today to treat severe hypoxemic respiratory failure. After my residency, I moved to Houston, Texas, to Texas Children's Hospital. I moved to the Mecca of medicine in Texas. I was being trained in a brand new pediatric subspecialty called pediatric critical care medicine. We take care of critically ill children after the age of 1 month and all the way up to adulthood. I then came back to Wilford Hall, and with the expertise I gained in my subspecialty training, we were able to modify our ECMO system to take care of a broader population of children. The size limit to that point was 10 kilograms. That's 22 pounds. We modified it to where we could take care of school-age children and even adolescents. We did this successfully. This is pediatric ECMO. We did not, at that time, however, perform adult ECMO. I was then recruited to the University of Texas Health Science Center in San Antonio in 1994. I was tasked with starting up a division of pediatric critical care medicine, and with hospital partners, Santa Rosa Children's Hospital, University Hospital, that's exactly what we did. And we did it really well, if I can say so myself. But what I did not do is I did not duplicate what was happening as a community asset at Wilford Hall. We did not do pediatric ECMO. We referred our patients to Wilford Hall who needed ECMO. Well, that was working great until 2004, 2005, and the war in Iraq caused staffing issues that led to the transfer of the pediatric ECMO program that I started in 1992 back to UT, to our critical care division. And with our partner hospitals, we began to perform pediatric ECMO. Now, the first time we did this at UT, I happened to randomly be on call that night. It was a Saturday night in 2005. I don't remember the date, but I remember the night. And there I was, 11 years after the last time I used ECMO as a tool, and 20 years after I was introduced to it, and I'm in the ECMO business again, taking care of very sick children. Today, my colleagues and trainees in the Division of Pediatric Critical Care Medicine at UT Health are providing ECMO to infants, children, and even adults. Now, I retired from UT in 2016 after 22 or so years, and I moved to New York City. What people who knew me did not know when I moved is that I had recently been diagnosed with a serious lung condition, fibrotic lung disease. Now, initially, I was doing great. I had no symptoms, my pulmonary function test looked good, and I needed no therapy of any kind. And that's how it went for 3.5 years. And in December of 2019, I literally fell out of an airplane without a parachute. I'm falling. All of a sudden, I'm short of breath all the time. I can't walk half a block. And my pulmonary function test tanked. By March of 2020, I'm on oxygen in New York, looking at a lung transplant at New York University. In March of 2020, COVID hit New York with a vengeance. And people like me with advancing chronic illness could not receive tertiary medical care in the city of New York. It was all COVID, all the time. So I came back to San Antonio and ended up on the day after I got here at University Hospital I'd worked in before. This time I was a patient and I was being evaluated for a double lung transplant. The following month, in July of 2020, I was put on the transplant list. That's a good thing, but what it means is you start the wait. And Karina, my wife, and I were waiting. And I was getting a little bit worse every day. My pulmonary function test went like this. I felt terrible and more terrible every single day. And my oxygen requirements went up like this. On November 16th of 2020, I was readmitted to University Hospital with respiratory failure. And the next day, I was on ECMO. I was on ECMO, not as rescue therapy. Everything I've talked about so far is rescue therapy. But this was to be used as a bridge to lung transplantation to enhance my chances of survival to transplantation and for me to be in the best possible shape. And so I went on ECMO to Brooke Army Medical Center here in San Antonio. Now, I was at Brooke Army Medical Center, San Antonio Military Medical Center, from the day I was transferred until the day I went back to University Hospital for a lung transplant. Things were different there. The diagram you see here looks almost like what I showed you before, except that after the artificial lung, the hyperoxygenated blood does not return to an artery, it returns to a vein. This configuration only supports failing lungs. It does not support a failing heart. And that was okay for me because my heart was fine. But I want to show you my device, my best friend for the entire time I was on ECMO at Brooke Army Medical Center. Now, remember the picture I showed you before? Well, if you went into my room, you could actually see me. And that device was mobile, it had wheels on it. Part of my therapy was actually to get up and walk around while I was on ECMO. And I expected to be on ECMO for 2 weeks because that's kind of what the plan was. But I had setbacks, I had complications, and here I am 1 month later at Brooke Army Medical Center, getting a suntan outside. I was on 100% oxygen on that ventilator, and I was on full-bore ECMO at that time. I was actually really, really sick getting that suntan. But I really want to say that demonstrates the outstanding quality of care that I got while I was at BAMC. And I will forever be grateful. Well, this is 1 month into it, and the weeks were passing. And the lung transplant was becoming somewhat elusive. And I was getting worse, slowly. And by the middle of February, as I was entering my 4th month on ECMO, I really began to believe that it was going to be end of days for me very soon. It was a long time on ECMO, and I had not had even anything close to an offer for lungs. But the last 3 days of February of 2021 were absolutely miraculous. The first thing that happened is a family graciously donated the lungs of their newly deceased relative to me. I was transferred back to University Hospital on ECMO and was successfully treated with a double lung transplant on the 27th and 28th of February of 21. And that was successful, and I'm here to talk about it today. What is remarkable about this story so far is I was on ECMO for 105 days. When I was an ECMO provider, we talked about stopping at 30 days for sure. And there I was into my 4th month. But you know, my story isn't really about me so much as it is about San Antonio. And the reason I say that is that I was introduced to ECMO at Wilford Hall. 35 years later, I was receiving ECMO in San Antonio. And I think it's an example of how great things are here in San Antonio for us who are in the health and bioscience community. It's actually a beacon. Now, what makes it so? Well, we have great institutions, research, education, clinical care. We have providers in the community. We have great technology going on. We have startups. But the glue that holds everything together is actually us. It's the relationships that we have individually and the collaboration that we have in this community. And so I'll end my little story with this. I can tell you today that with absolute 100% certainty, that's 100% absolute certainty, that if I had not returned to San Antonio, and only San Antonio, in May of 2020, there would be no story to tell because I would not have survived. Thank you very much.